Dr. Chanik, you may call your first witness.
I'd like to call Dr. Richard Krasuski to the stand. Dr. Krasuski, as you heard from the other side, there seems to be this emphasis on 25 millimeters of mercury in terms of the pressure above which it's okay to treat patients and below which it's not, is my understanding. What is it about 25? Is there some magic about 25 millimeters of mercury?
Well, Dr. Chanik, I don't think there is. I think this is just an arbitrary number.
Do you know where the cutoff came from of 25 millimeters of mercury? I mean, we talk about evidence-based. I mean, tell us about where that came from.
Sure. Well, the first World Symposium on Pulmonary Hypertension back in 1973, this was the arbitrary definition that came out of that. There have subsequently been multiple World Health Symposiums, and that definition is held since that time.
So what you're saying then is that the very definition or previous definition of pulmonary hypertension is not evidence-based.
That's correct.
Objection, Your Honor. He's leading the witness.
That objection is denied. I want to see where you're going with this, Counselor.
And in fact, what is a normal pulmonary artery pressure if you really do look at evidence?
Yeah, so recently there have been some studies trying to examine this. It looks like probably the normal mean PA pressure for the general population that's healthy is roughly about 14 millimeters of mercury plus or minus 3 millimeters of mercury. So that would mean that 20 would be considered sort of the upper limits of, would be certainly considered outside the upper limits of normal.
Right, so 23 or 24, for example, would be quite abnormal. Would you agree?
That's correct.
Now, Dr. McLaughlin on the other side talks about randomized controlled trials showing appropriateness of treatment. Let's talk about that a little bit. Would you agree that as an experienced clinician, clinical judgment and experience does play a role in making treatment decisions?
I absolutely agree with that. I think you have to use your common sense as well when you approach a patient, and if they're symptomatic, then obviously that's a major concern.
Thank you. And in your wealth of experience, and I don't think we said you work at Duke University Medical Center?
That's correct.
Which is one of the leading institutions in the world?
I think so.
Objection, Your Honor. Calls for judgment.
Sustained. I'd like you to keep commentary about the witness's institution out of this proceeding, counsel.
So in your wealth of experience, both at Duke and I think you were at the Cleveland Clinic before then?
Objection, Your Honor. The background of the witness
Counselor,
has no
you're in
relevance.
thin ice right here. I've already instructed you not to use his institution as qualifying. This is a data-based argument, if you will.
Thank you, Your Honor. Just giving the jury some background on the witness. But that 20 to 24 millimeters of mercury, have you ever seen patients that you felt, in your experience, had symptoms due to that degree of pulmonary hypertension?
Yes, I've definitely seen patients in that range of pulmonary pressures who've been symptomatic.
And when we talk about what those mild elevations of pulmonary artery pressure really means, do you know of any data supporting that pressures in that range can affect outcome or at least associated with worse outcomes?
Yeah, so there have been a few studies that have specifically looked at that range of pulmonary pressure elevation and have actually shown that the mortality is actually higher in those groups. And not only that, but their 6-minute walk distance, their peak VO2 by metabolic stress testing have actually shown reduction in exercise tolerance as well.
Suggesting that that degree of pulmonary hypertension actually can cause clinically significant problems.
Both
Is that correct?
symptoms and increased mortality.
Wait,
That's right.
objection, Your Honor. This study, while it did demonstrate a reduction in exercise tolerance as PA pressures increased, did not demonstrate the cause and effect. Clearly, these patients had other comorbid illnesses which could have contributed to their symptoms of dyspnea as well.
I'm sorry, Your Honor. I'm going to have to object to her objection. She's making her case during my examination of the witness.
She's allowed to object. You are not allowed to object to her objection.
There has to be a basis
Your
to the
objection
objection.
is denied. He said suggest. He did not say cause and effect, so I will allow it to continue.
Thank
Please
you.
proceed.
So if we have these mild elevations in pulmonary artery pressure, you showed that physiologically this degree of elevation can cause problems. What about the effect on overall outcome? Do we have studies supporting the effect of pulmonary artery pressure elevation or association, again, with worse outcomes?
So there's been a series of small studies, actually, that have tried to examine specifically what happens when the pressure is elevated to that degree, and they've all pretty much shown that there's an increased risk of mortality with that degree of elevation.
Thank you. So higher mortality with pulmonary artery pressure elevation in that range.
That's correct.
Thank you. Now, let's turn a little bit to your views on treating these patients with pulmonary hypertension in that 20 to 24 range. What evidence is there? Well, before we start that, let me ask you, do the data that you've seen and your experience at least provide a rationale for why one might consider treating patients with pulmonary hypertension in the 20 to 24 range?
I think the evidence is suggestive enough that it's reasonable to consider treatment in these patients.
They're symptomatic, you have physiologic abnormalities, and they may progress.
Objection, Your Honor. He's answering his own question for the witness.
Denied. He's summarizing the statement of the witness, and I will allow it.
So with that rationale, let's talk about treating borderline PH, or what we may actually call pulmonary hypertension in the future.
So there have been a few small studies. One in particular looked at the benefit of giving a dose of either nitric oxide or riociguat, which showed that in a population of patients with COPD and pulmonary hypertension, that there was a reduction in both the mean PA pressure and the pulmonary vascular resistance with the use of those particular interventions. That was statistically significant. Then there was another study specifically in patients with idiopathic pulmonary fibrosis where they randomized folks to receive either therapy or not be treated. The group that was untreated had a progression, actually, where their mean PA pressure and their pulmonary vascular resistance progressed, whereas the group that was treated medically actually had evidence of a reduction in the mean PA pressure and the pulmonary vascular resistance, therefore suggesting that this is a therapy that slows the progression and possibly improves how people do long term.
So just again to summarize, these studies show very objective, irrefutable evidence that there's a hemodynamic effect of the two agents that you mentioned, riociguat and bosentan, in patients with pulmonary artery pressures in the 20 to 24 range. So
I believe that's a very fair statement.
Objection, Your Honor.
Sustained. Irrefutable is a very strong word, and I'm going to caution you to watch it, Counselor.
Okay, so let's, with that in mind and everything that you've talked about, do you think a redefinition of the hemodynamic definition of pulmonary hypertension is warranted?
I do.
To call pulmonary hypertension?
I think over 20 is a reasonable new definition as opposed to waiting for it to be 25 or higher.
And you've showed data to support that?
I think it supports completely that that definition should be used. If that impacts morbidity and mortality, I think it's fair for us at this point to look at that group as a high-risk group.
So so there's plenty of evidence to support your conclusion that?
I agree, yes, I do. I think there is.
And just to summarize, pulmonary hypertension is a serious condition.
High morbidity, high mortality condition, particularly when untreated. I think we have evidence now that treatment increases survival and that it also limits symptom progression. I think that's very important, rather than waiting for the disease to progress to the point that it's irreversible or therapy may have less of an effect.
And then finally, with all that in mind, everything you've said, just to personalize, if you had a pulmonary artery pressure of 20 to 24 millimeters of mercury and you had symptoms that were due to the pulmonary vascular disease, would you want treatment for your pulmonary hypertension?
Objection, Your Honor. This is really out of the scope of the argument that we're trying to make, what Dr. Krasuski's personal feelings are about his personal health.
Okay, if Dr. Studer had pulmonary hypertension.
I'm going to deny her objection and allow you some latitude, but not in using me as the ill individual.
If it were me or Dr. Studer, I would want to be treated, and I think he probably would too.
I have no further questions.
Thank you. Dr. McLaughlin, you may question this witness.
Thank you, Dr. Studer. Dr. Krasuski, thank you for being here today. While there is nothing, quote, magic, to use my opponent's terminology, about a mean pulmonary artery pressure of 25, has it not been the threshold for enrollment into every single clinical trial to date that has led to the FDA approval of the agents that we currently have in our armamentarium to treat pulmonary arterial hypertension?
I think that's a fair statement.
In fact, pretty much every trial has used, at the very least, a mean pulmonary artery pressure above 30 with a wedge pressure of less than or equal to 15 and a calculated pulmonary vascular resistance of greater than 3 for entry. Is that not correct?
That is correct.
Thank you. So when we talk about evidence-based medicine, if we have evidence for a certain condition and we think that maybe we know a precondition that might be treated, we should really test that evidence rather than assume anything. Isn't that correct?
I think in certain conditions that may be true, not necessarily every condition.
Can you cite a condition in which our exuberance to treat what we thought was a precondition led to an adverse outcome? You're a cardiologist. Have you heard of the CAST trial?
I'm going to object to that. The CAST trial is not related to pulmonary hypertension. The argument today.
I'm going to deny that objection and fire to the same latitude I did for you, Counselor.
Can you tell us about the CAST trial, Dr.
Sure.
Krasuski?
I think for a while there was the idea that if you suppressed premature ventricular contractions, that you could actually improve clinical outcomes, prevent mortality. So they, until that was actually studied, they used the drugs enconide, flecainide, and maricazine to try to suppress PVCs, but instead of actually reducing mortality, it actually increased mortality. And it took us by surprise.
It did take us by surprise, and this is one of the reasons why we as scientists, as physicians, rely on evidence-based data. Could we not make the same correlation that perhaps while we think it might be good to treat a precondition, we really don't know the outcome until we do the well-designed randomized controlled
that
trial?
Presupposes that, I think with pulmonary hypertension, we already have evidence that treating pulmonary pressures reduces bad clinical outcomes, where I think we never had that data with suppression of PVCs in any population. So I think that is not really a valid argument.
Dr. Krasuski, I mean, I think it's a similar situation. We know treating VT will improve outcomes, so treating PVCs, it was a theory. It's the same situation here. We know that treating a mean pulmonary artery pressure over 25 improves outcome, and we're assuming that treating a PA pressure between 20 and 24 does. So I do think it's a very similar situation. Let's move on a little bit. You cited a very impressive study that showed as mean pulmonary artery pressures go up, the patient's exercise tolerance go down, the 6-minute hall walks go down, the CPET, the VO2 max goes down, and the mortality goes up. You reviewed that earlier, correct?
That's correct.
So that patient population, was that a PAH patient population, or did those patients have other comorbid illnesses?
No, they had some comorbidities.
Such as?
Such as lung disease, and some of them had, some of the other studies I mentioned have heart disease as well, left heart disease.
So those lung diseases and that heart disease, could they potentially be the cause of the patient's dyspnea?
It's a possibility, but we do think that the pulmonary pressures did play into this.
On what basis? How do you know that?
Well, the way the analysis was done, I think they tried to focus specifically on pulmonary pressures.
So the analysis was done by pulmonary pressures, but they didn't really tell you much more about the COPD or the left heart disease and whether that could have progressed.
Well, I think that's a weakness of almost all the epidemiologic studies.
It certainly is a weakness of that one, on which my opponent is basing quite a bit of his argument. And in fact—
Objection.
Denied.
Argumentative.
Overruled.
In fact, in some of the trials justifying therapy, you quoted pulmonary hypertension in the setting of other illnesses. In fact, the one that acutely lowered PA pressure, that was a study of patients with COPD. Is that not true?
That is correct.
Right. And the other trial was in patients with IPF. Is that not true?
That is right.
So when we see patients who have lung disease or left heart disease as clinicians, What therapy do we recommend for them generally?
We typically treat the underlying
We
disease.
typically do treat the underlying disease. Do we throw pulmonary hypertension medications at those patients?
I think the quick answer to that is no.
No.
But,
Is there any
but,
evidence?
But I would
Yeah,
say a lot of people do.
Is there any evidence to use pulmonary hypertension therapies in patients with underlying lung disease or heart disease?
There is some, but I would say it's a pretty weak evidence
Any
field.
randomized controlled data that is potentially label enabling or would lead the FDA to approve these therapies for those conditions?
Not to this point.
Not at all. In addition, part of our definition is a pulmonary vascular resistance of greater than 3 Wood units, correct?
That's right.
Right. Some of these patients who had these very modest elevations of pulmonary artery pressures, did they all have a pulmonary vascular resistance of greater than 3 Wood units?
No, but some did.
What proportion did?
It was probably a third or so.
Yeah, probably a very small proportion. So if you have these patients with underlying lung disease and maybe this mild elevation of pulmonary artery pressure with a normal pulmonary vascular resistance, is it possible that their shortness of breath really has very little to do with the pulmonary hypertension and more to do with their underlying comorbid illnesses?
It's possible.
And in fact, when even you look at the survival curves with the higher mortality in those patients, isn't it possible that that higher mortality is really more a result of their heart disease and their lung disease than of the pulmonary hypertension?
It's possible, but
Thank you, Dr. Chan, or Dr. Krasuski. So let's say we do agree, and in fact, I do agree with your argument about the fact that a mean pulmonary artery pressure between 20 and 24 is abnormal. There's no question that's abnormal. But does that mean that every individual with a mean pulmonary artery pressure of 20 to 24 should receive PAH-specific therapy?
no, but I also don't
Thank
think...
you for answering the question, Dr. Krasuski. Let's also take into account that we are then condemning that patient, if we were to treat them, to lifelong therapy. What about the expense and side effects of the PAH-specific therapies in such a patient?
Well, I don't think these drugs could ever be considered inexpensive, and there are some side effects, but most of us would think that they're pretty manageable.
Manageable, but when you have a disease that is advanced enough for us to feel very confident that that therapy will make a difference, such as the patients with mean pulmonary artery pressures over 25 that have been studied in trials that demonstrate efficacy of those therapies, wouldn't you perhaps consider the risk-benefit ratio a little differently in a patient in whom those therapies had not been studied and demonstrated to be efficacious?
I think there would be a lot I would put on the table to discuss, and one would be, of course, how symptomatic they are and what their prognosis is. But I don't think you can just make a blanket statement that you wouldn't treat. But
And that's what we're here to argue today. Let me ask the question a different way. So we haven't really studied this patient population all that well. I mean, there's some epidemiology in some mixed populations. Can you envision a patient with a mean pulmonary artery pressure of 21 or 22 who will live many years, not really ever have symptoms from that, and ultimately succumb to something else?
I'm sure those exist, yes.
I'm sure those exist. And my opponent is suggesting that all of those patients should receive these therapies despite that fact.
Objection. That was not our argument, that all patients should receive those therapies.
Oh, but that's what I understood your argument to be, the majority, counselor. Is that not what's on trial here?
Dr. McLaughlin said all patients.
Can you imagine that there would be a number of patients with a mean pulmonary artery pressure of 21 who may never have any symptoms and would succumb to something else and would have then been treated with these therapies that do have expense and do have side effects needlessly?
I think there are, again, some that will benefit and some that won't benefit.
Okay. Thank you very much, Dr. Krasuski.
Thank you, Dr. Krasuski. You may step down. And Dr. McLaughlin, you may call your first witness, please.
Our case moves on now with Dr. Preston on the witness stand.